Welcome to MycoClinics on this sunny afternoon, at least in the UK. And we will have an exciting session about clinical challenges of antifungal resistance. And we have two excellent speakers lined up to show us a case study with diagnostic considerations and processes, treatment deliberations, follow-up and outcomes. And at the end of the two presentations, we will have a discussion together. Please do submit your questions during the presentation through the Q&A session, and we will try to aim to get back to all those questions during the discussion at the end of the MycoClinics sessions. Please note that we will record the session and they will be available on the YouTube channel on our website. So for today, we have two speakers, Professor Paul Verweij from the Netherlands and Professor Neil Clancy from Pittsburgh in the United States, and we will introduce them later when they start presenting. I am sharing this MycoClinics session with my colleague, Dr. Tihana Bicenik from St. George's Hospital in London. Before we kick off, I also want to draw your attention to two other webinar series we are providing. The next MycoTalks will be on the 29th of June. And during this MycoTalk seminar, Agustino Carvalho and Duncan Wilson will be presenting about their work. And specifically for trainees, there is a trainee seminar series which you can find the link in the chat, where trainees present their work virtually to a global community. All talks are on the second Thursday of the month. And now, without further ado, I would like to introduce our first speaker for today. And it's a pleasure to introduce Professor Paul Verweij from the Radboud University Medical Center. He's a consultant microbiologist and a professor of clinical mycology. He's a board member of the Center of Expertise in Mycology at the Radboud UMC and the Canisius Wilhelmina Hospital in Nijmegen, and director of the National Mycology Reference Lab. And he also has an appointment at the Dutch National Institute for Public Health and the Environment. His main interest is the management of invasive fungal disease, and amongst the topics of interest is the emergence of azole resistance in Aspergillosis, and he has been one of the first to address the origin and the epidemiology of azole resistance in Aspergillosis, and also to come up with clinical management approaches. And he is going to share with us a case about the clinical challenges in the management of azole-resistant Aspergillosis. Paul, over to you.
Thank you, Adelia, for your introduction. Let me share my screen. So I would like to present a case which we had in our institute 2 years ago, who was managed by our intensivist Jeroen Schouten and a resident in internal medicine, then working at the Department of Nephrology, Rob Schamp. So this case is about a female who was 33 years old, and her history tells us that she had kidney insufficiency, which was diagnosed in 2008 due to focal segmental glomerulosclerosis. And in December 2012, she underwent a kidney transplant. So the period after the transplant was complicated with multiple rejections and treatments for that. And in December 2014, she had to restart with peritoneal dialysis. But in 2020, in February, she underwent a second kidney transplantation, and she received immune suppression for that. because of high immunization induction, she received alemtuzumab, and also at least 1 year of triple immunosuppressive therapy, which included prednisone, tacrolimus, and MMF. So in 2020, in October, at the end, she developed COVID-19 disease. She had a positive PCR test. And a week after that, she was admitted to the hospital because of progressive respiratory complaints. The treatment was started then with remdesivir and convalescent COVID-19 plasma, because although she was vaccinated, there was absence of a conversion, and she had this recent treatment with alemtuzumab. And she was also had a persistent lymphopenia. But her clinical condition deteriorated, and she was then submitted to the ICU in November, and she underwent intubation and ventilation. So she stayed in the ICU for a long time, and in January on the 6th, she received a tracheostoma. And at the end of January, she underwent decannulation, and finally, she was transferred back to the ward. So during the ICU admission, we take, in the Netherlands, bronchoaspirates from these patients twice weekly, and they are looked for gram-negative bacteria, but also they are cultured for the presence of fungi. So during her time in the ICU, 20 bronchoaspirates were collected, and all of them were culture negative for fungi. But on the 24th of January, she developed fever, and the blood cultures were taken, and a new sputum culture was taken. And the blood culture was positive with a Klebsiella pneumoniae, which was multi-resistant and was treated with meropenem. But then for the first time, a sputum culture, the fumigatus. So this was right at the end of her stay at the ICU, and in a time where she improved clinically, also her respiratory function was improving, and she was made ready for transfer to the ward. So this is my first question related to this positive sputum culture, because the question is, what would you do in this situation? So would you consider this a sign of upper respiratory tract colonization, and would you need no further action? Or would you do a diagnostic workup in this patient by doing a bronchoscopy and BEL? Or would you look for circulating biomarkers such as beta-glucan or galactomannan? Would you do a CT scan to see if there are suspected lesions for COVID-associated pulmonary aspergillosis? Or will you do all those diagnostic procedures? Or would you start antifungal therapy in the console? So please vote. Okay, so that's very interesting. So the majority actually would do a full diagnostic workup, 72%. One person would start antifungal therapy, and some of you would just do a part of the diagnostic workup, and only 3 of you would interpret this as a respiratory colonization. So if you look at the diagnostics test for Aspergillosis, the performance of tests is variable. As you might know, these patients may be colonized with Aspergillus. Colonization might progress to invasive disease, and that will be tissue invasion, and ultimately these patients might develop angioinvasion. So if these patients have a positive sputum culture, the positive predictive value for kappa is quite low because also colonized patients will have a positive sputum. Bronchial aspirate has a bit of better performance with a positive predictive value of about 20%. And a non-bronchial lavage, where you sample the lower respiratory tract, has an even better performance. But usually it's recommended to do a bronchoscopy and then BEL. So serum biomarkers, if they are positive, they indicate that you have angioinvasion. So you have quite far progressed disease. And in most patients, this test will be negative, and only up to 15% of patients have circulating biomarkers if they have kappa in the ICU. So another thing we have to take into consideration is that this patient had a solid organ transplant. And that was one factor which was shown to be associated with death in patients who develop kappa. And also the presence of kappa itself has an increased risk of mortality. So the positive sputum culture was reported on the 28th of so that the day that the patient was decannulated and was made ready to go to the department. And we know that most kappa cases occur earlier in the phase of the ICU stay, and most of them develop it on day 8. So if you look at the institutional guideline we have in our institute, and this is also in alignment with international guidelines, suspicion of kappa in ICU patients is when you have a positive sputum culture in a ventilated patient, or you have an unexplained respiratory deterioration. So if you have that, then it's recommended to do a bronchoscopy with BL and then look at the biomarkers, galactomannan, PCR, and culture. So this patient did not fulfill this criteria because there was no respiratory deterioration. Actually, the patient was improving. And also the patient was no longer ventilated. So in this patient, we decided not to do a diagnostic workup and to consider this positive culture as colonization. Also because during the whole ICU period, we were monitoring for the presence of fungi, and that has always been negative. So if we think that this culture is clinically relevant, my next question would be, would you request for an MIC test? So maybe you never do that because you think, well, an MIC wouldn't have impact on my treatment choice. The second option is hardly ever, because the strain would need to be sent out to maybe a mycology reference lab, and then the results come in much too late to be of any clinical relevance. Or do you request an MIC test if the patient fails to antifungal therapy? Or do you do that in any clinically relevant Aspergillus isolate? So please vote. Okay, so there's very interesting. About half of you would do MIC testing in any clinically relevant isolate. And 35% would request an MIC test if a patient is not responding to antifungal therapy. So if you never do it, probably you don't believe that is any relevance. Well, nobody voted for this option. But there are clinical studies which indicate that resistance does have an impact on the survival of patients. And this was a study performed in 3 centers where the survival of patients, or the all-cause mortality, was compared between patients who had a voriconazole susceptible isolate compared to those who have a voriconazole resistant isolate. So this study showed that the survival rate was 21% lower in patients with a resistant isolate after 6 weeks of treatment, and it was 25% lower on day 90, indicating that resistance does have an impact on the survival of your patient. However, if you look in intensive care unit patients, and this was a smaller group of 59 patients, you can see that the difference was no longer significant because the mortality was high both in voriconazole-resistant infected patients and voriconazole-susceptible infected patients. So some of you voted for the fact that they hardly ever do an MIC test because you have delay because it has to be sent out. So is it relevant if you have delay? Well, in the same study, the effect of immediate appropriate antifungal therapy was also investigated. So there were 154 patients who had an invasive aspergillosis who started on voriconazole therapy. The culture became positive, an MSC test was done, and if it was voriconazole susceptible, they continued on voriconazole, which was appropriate treatment. And if it was voriconazole resistant, then it was switched to appropriate antifungal therapy. So there the initial treatment was inappropriate. So if you compare those two groups with respect to survival, you can see also in this analysis that there was a 23% difference in survival. So patients who first received inappropriate antifungal therapy had a higher mortality rate. So the median time to switch was actually 10 days, indicating that it takes quite a long time before you have the results back for the MIC test. And if you look at the two graphs, you can see that they split up quite early already. So I think this tells us that the initial treatment should be appropriate and is critical also for the survival of your patient. So many of you voted to do an MIC test in patients who are failing azole therapy, and that is also what the IDSA guideline recommends. And I think that is an approach which you could follow in a low endemic area. And all clinically relevant isolates, I think, is a very approach, which is also recommended by the ESCMID ECMM ERS guideline. And especially if you are in an area where you know that azole resistance is present. So the isolate was analyzed, and it turned out to be an azole-resistant isolate. So the MIC for amphotericin B was 0.5, which is susceptible. But then we have listed here 4 azoles: itraconazole, voriconazole, posaconazole, and isavuconazole. And the MICs, which are shown in red, are in the resistant area. So these are resistant to all the 4 azoles. Then we have the 3 echinocandins: anilafungin, caspofungin, and mycofungin. And we have no breakpoints for those agents, but you can see that the MEC of these drugs is very low. And the bottom one, we have olorafim, which is a new antifungal which is in development, which also showed a low MIC. So the isolate was further analyzed, and it turned out to have a 10-repeat 34L98H mutation, which we recognize as an resistant mutation associated with environmental resistance selection. So what happened to the patient? Well, the patient was discharged to a lung rehabilitation center, and then she went home, but she still had persisting oxygen need. And one of the problems was that she had recurrent urinary tract infections with this Klebsiella bacterium that required treatment with meropenem because there were no other treatment options. And for that, she had short hospital admissions. So to try to find a source for this recurrent bacterial infection, a PET-CT scan was made in March of 2021. And the question was, could we identify some kind of source for this bacteria, for this bacteremia and infection. So the PET scan, it showed diffuse uptake of FDG in the lung, which is common in a post-COVID setting. But there were also two nodules in the lung, in the upper lobe, which were thought to be possible secondary infectious foci. So then an HR high-resolution CT scan was made, which showed no clear infiltrates against the background of extensive post-COVID-19 lesions. So it was then decided to refer the patient to a pulmonologist in 3 to 4 months for follow-up CT scan. So here you can see one of the images of the PET CT, and you see that there's this nodule which lights up. And this was 65 days after this positive sputum culture. And this is the CT scan, and there are no clear evident infiltrates, although you see a lot of lesions associated with this COVID infection. So in the months after that, the patient experienced an acute rejection of the kidney transplant, and she received further immune suppression for that, methylprednisone, IV IgG, and plasmapheresis. And the scheduled meeting with the pulmonologist took place in July of that year. So she was seen by the pulmonologist, but the PET CT scan was not performed. So she then went on, because of this persistent oxygen requirement, to the outpatient lung rehabilitation center, and she was followed up with lung function tests and with X-rays. So then in November, she had another meeting with the pulmonologist, and the low-dose CT scan of the thorax still showed extensive pulmonary lesions, which were thought to be due to the COVID. But 1 week later, she saw that she developed skin lesions, which over 1 week in the chest wall and on the right upper leg, and she was referred to the dermatology. So here you can see the skin lesion, and it was decided to take a skin biopsy. So the pathologist looked at the biopsy and thought it was an early manifestation of erythema nodosum. And several stains were performed, including a Crocott stain, and there were no microorganisms seen, and also the cultures remained negative. At the same time, the patient complained of pain in the right hip, and she went to the orthopedic surgeon. And he said, well, I don't see any evidence for septic arthritis, and did not see any further action from his side. But at the same time, it was noticed that she had developed new skin lesions. So together, they decided to do an MRI of the right leg and schedule for a new skin biopsy. So here you can see the MRI scan, and you can see that there is evidence for extensive multifocal osteonecrosis. So this was 304 days, so nearly a year after this positive sputum culture in the ICU. And the next day, the tibia was biopsied. So we received 6 biopsies in the lab, and all 6 of them were positive with Aspergillosis suspected for fumigatus. So here's my third question. So this patient had a previous azole-resistant isolate. So which antifungal treatment would you start in this patient? Would you consider this likely an azole-susceptible infection, and would you start with voriconazole or isavuconazole? Would you start with liposomal amphotericin B, or would you prefer voriconazole with anidilafungin, or voriconazole with liposomal amphotericin B, or posaconazole with anidilafungin, an echinocandin monotherapy, or would you try the new drug olorofin? Okay, so there's quite a lot of diversity in approaches, so that is really interesting, and I think that will lead to a very interesting discussion. But the majority would start with liposomal amphotericin B in this patient, 47%. But also a number of you would choose combination therapy, voriconazole with liposomal amphotericin B, or posaconazole with anidulafungin. And also 12% trust the new olorofim antifungal. So let's look at the different options and consider the pros and cons. So I think azole monotherapy, if this is an azole-resistant isolate, you have a high failure rate. And I think even though it was nearly a year ago that the isolate was cultured in the ICU, I think we would take that into consideration. So the other option is liposomal amphotericin B, and this is the recommended treatment in a patient where you prove the presence of azole-resistant invasive aspergillosis. So at this time, when we had to make this decision, we still didn't have the species identification and the MIC test, although we thought it was really highly likely that this was also an azole-resistant isolate. So one of the problems is that if you start liposomal amphotericin B in this patient, you have a probability of nephrotoxicity, and you might have to give up the kidney transplant. So this is something which you could consider. It also might then enable you to reduce the immune suppression. But this is, of course, a young patient who had the second kidney transplant. So that's something you have to consider. So the other option is to combine voriconazole with liposomal amphotericin B. And this is a combination which is considered, especially when you anticipate mixed infection. And mixed infection means that you have an azole-resistant and an azole-susceptible infection at the same time. So the idea is that patients inhale susceptible and resistant spores, and that these can grow out to cause lesions. And we think that about 40% of patients actually have a mixed infection. And the other underlying idea is that azoles might be more effective than liposomal amphotericin B against azole-susceptible invasive aspergillosis. Again, of course, if you start liposomal amphotericin B, you have to take into account the possibility that there will be nephrotoxicity. But if you look at the activity against Aspergillus, including azole-resistant, this is probably the most potent combination. So what about echinocandin monotherapy? Well, we saw that the MECs are very low, but we know from studies, clinical studies in neutropenic hematology patients, that the efficiency was lower than for the azoles. And one of the problems is that echinocandins are not fungicidal against Aspergillus. They just affect the cell wall, and they don't actually kill the cell itself. So the other option would be an azole and echinocandin combination. And then we have, of course, various options. You maybe choose voriconazole or posaconazole, and the question is, does it matter which azole you choose? So if we look at this 10 repeat 34 isolates, and this is an analysis of a few hundred of those isolates, and you look at the MICs, you can see on the left itraconazole, and in the blue dots, you can see the activity of the azole. And with ITRA, you can see that the largest dot is right to the right with an MIC of 32. And that means that most isolates, if they have this mutation, have very high MICs to itraconazole. For voriconazole, you can see that it's more spread out, and that some isolates have low MICs of 0.5 and others 32, but the majority have a MIC around 4 milligram per liter. With posaconazole, you can see that most isolates have an MIC of 0.5, while isavuconazole has a distribution which is more similar to voriconazole. So if you then compare it to the wild type, you can see with ITRA that there's a large difference between the concentration that inhibits wild types compared to the resistant population. For voriconazole, the distance is a bit closer, which is also the case for isavuconazole. But for posaconazole, the wild type population and the resistant population are actually very close to each other. So what does that mean? Well, if you look at the efficacy of azoles, the AUC, that means the total dose of drug you give over 24 hours, divided by the MIC gives the best prediction of efficacy. So if the MIC is increased, then you would need to increase the dose of your antifungal to be able to achieve successful treatment, or at least a pharmacodynamic target. So if the resistant population is very close to the wild type, it means that maybe if you give a higher dose, you will still be able to treat these resistant isolates. So on the right, we have a table showing this for posaconazole. And for each MIC, it was calculated what kind of level to achieve to be able to achieve the pharmacodynamic target. So if you look at 0.5, which was the MIC of the isolates which we cultured, we see that the trough concentration of posaconazole should be above 3 milligrams per liter. And we know that this is an achievable target, especially in patients who receive intravenous posaconazole. So within the azole group, we thought in this patient that posaconazole would be effective if we could get a higher exposure. So finally, we have olorafim as a treatment option, and this is an exciting new drug, which is a new mode of action, which is a DHODH inhibitor. So at this time, it's still investigational, and if we want to use it for this patient, then we would have to call John Rex and ask for it for compassionate use. But phase 2 studies results are very promising in patients with azole-resistant invasive aspergillosis, and currently there's a phase 3 study ongoing. And we know that the drug was active, at least in vitro, against the isolate of our patient. One potential drawback is that this drug is only orally available. So we got the MIC results of the second isolate, which is here presented on the right, and the first one from the ICU on the left. And you can see that the MICs are very similar, and that the posaconazole MIC is 0.5. So in this patient, we decided to start treatment with posaconazole and anidilafungin combination, and to do TDM and posaconazole to get a high level of exposure in this patient. Also, it was decided to repeat the PET CT scan and also to give anakinra. So here you can see the PET CT on the left. It was the first one done in March 2021, and on the right, the second one, which was performed in December. And you can see that the lung lesion has increased in size, and you can also see that there are multiple lesions on the right leg, which fits with disseminated invasive aspergillosis. So this is the PET of the lung, and on the bottom right-hand side, you can see the first one, and in the middle, the second one, you can see that the lesion has increased over time. Also, a CT angiograph was done, and it became clear that one of the lesions was very close to a pulmonary vein, and we were afraid that there was already invasive growth in one of the blood vessels. So we decided to ask for a FIM, and the patient was started on that on the 7th of December. Unfortunately, the patient also developed a severe respiratory insufficiency due to RS virus infection, and she had to be admitted to the ICU. In the ICU, interferon gamma was administered, and also it was decided to give up the kidney and to stop immunosuppressive therapy or to reduce it. However, the patient developed progressive multi-organ failure, progressive respiratory failure, and needed progressive hemodynamic support. We looked if there were any surgical options for interventions, but we could not operate her in this condition. We added liposomal amphotericin B, but unfortunately, she died on the 24th of December.
Paul, can I ask you to draw it to a close, please?
Yes, this is my nearly my final slide. So if you look at these three periods, we have the ICU period, the rejection treatment period for the kidney transplant, and the period of disseminated invasive aspergillosis. We wondered what was the pathogenesis. And we looked at beta-glucan retrospectively, and we found that this was negative during the ICU admission, but became positive shortly before the kidney rejection treatment was started. And we also looked at galactomannan, and that was actually negative all the time and became positive only when the patients had evidence for disseminated invasive aspergillosis. So the reflection on this case, of course, we considered, could we have done better? Could we have foreseen this disease progression? And especially, how do you interpret this culture in the ICU, this positive lesion on the PET-CT scan, and also what should you do during rejection treatment of the kidney transplant? So this was my final slide, and I thank you for your attention, and I look forward to a discussion. Thank you.
Thanks, Paul. That was a very interesting and challenging case. I'm sure there will be lots of aspects to be discussed later on. I'm going to hand over to Hannah, who will introduce the next speaker.
Thank you very much, and thank you, Paul, for that brilliant case. I mean, really illustrative of so many of the challenges of managing these complex patients, and also brilliant nuggets around azole-resistant aspergillus. So we're also delighted to have a fantastic second speaker for you, this time on the topic of candida resistance and abdominal candidiasis. We have Dr. Neil Clancy from Pittsburgh. He's Chief of Infectious Diseases at the Veterans Affairs Pittsburgh Healthcare System, Professor of Medicine, Associate Chief of Infectious Diseases, and Director of the XDR Pathogen Lab at the University of Pittsburgh. His research is funded by NIH, and he has an interest in molecular mechanisms of pathogenesis and also antimicrobial resistance in Candida, as well as carbapenem-resistant gram-negatives. He is also chair of the Infectious Disease Society of America Committee on Treatment Guidelines for AMR gram-negatives, and sits also on EORTC and MSG fungal disease definitions committees. And he has many publications on the topic of both diagnosis and management of invasive candidiasis, including intra-abdominal candidiasis, as well as resistance in Candida, and he will be presenting a case for us on this today. Thank you, Neil, for speaking to us.
Great, thank you. It's great to be here, and I'm sharing my screen. Is the title slide showing up okay for you?
Yes, thank you.
Very good. So let's get right into it, and I'll start with a typical case at the University of Pittsburgh. This is a 64-year-old man who underwent a right hepatectomy with a Roux-en-Y biliary reconstruction and a colodocoduodenostomy for what ultimately proved to be a non-malignant hepatic mass. So I'm assuming you can see my cursor. I'm pointing at the two red circles here, which are anastomotic sites that are prone to leak and complications following this type of surgery. And initially, for 2 weeks postoperatively, he did pretty well, but then he developed fevers and worsening leukocytosis. And here's his scan. He's lying on his back. You can see the red circle here where contrast dye is extravasating from the small intestine through the anastomotic site up into the biliary tree. And he has what looks to be a perihepatic abscess. So he started on broad spectrum antibiotics. He undergoes surgical drainage, and the ID team is called to ask, should we go ahead and start an antifungal agent on this gentleman? So to answer this, the first question you ask yourself is, what is the likelihood that this gentleman has a Candida intrahepatic abscess at this stage of the game? We don't really have any data back on a workup as yet. So there's a range of choices there which you can consider. And the precise numbers probably aren't as important as a general ballpark, really low, moderate, really high. The last choice is really what the critical care and surgeons want. Just, tell them what to do. So I'll give you a moment or two. I don't really see a timer. I don't know if I end this or if it's ended for me.
I'll end it when around 60% of people have voted.
Okay, very good. Of course, in the United States, we don't even get that for presidential elections, so I hope I do a bit better. Okay, and that's sort of an even spread. Looks like it's sort of skewed toward the 15-30% range. Excellent. Okay, and then the second part of it is, given the likelihood, then is antifungal treatment justified, and if so, what agent are you going to give? So approaches might be to say, what, I'll hold off. I won't give the agent right now. I'll see if I get cultures back. I'll hold off. I'll see how the patient does. If he's responding to drainage and the antibiotics have been started, I'm okay holding antifungals even if the abscess culture subsequently reveals a Candida. And then you've got treatments to treat right now. And do you want to give a fluconazole? Do you want to give an echinocandin, or do you want to give a lipid formulation amphotericin B? Okay, so sort of equally divided between, hold off, and if you get a positive culture, treat, to starting up front with fluconazole or an echinocandin. Very good. So we'll return to these. Let's get back to the case, though. So he was treated initially with fluconazole, then subsequently some data came back. So at our center, we have a serum T2 Candida assays that's done, get that back typically within about 5 hours. And this was positive for Candida albicans / Candida tropicalis. However, then subsequently the abscess culture, while positive for E. coli and vancomycin-resistant enterococcus, did not reveal Candida. And similarly, the blood culture had the E. coli, but was also Candida negative. So we don't really even need to vote on this one, but you might think then, does this change the likelihood of abdominal candidiasis in this patient? And if so, how? Does it make it more or less likely, given that you've got these discrepant culture and T2 Candida results? And with that, is it going to change your decision-making in this case? So in the interest of time, you can contemplate those. I'll return to them later in the case as well. But when we talk about invasive candidiasis, I think those of us from a medical background think primarily of candidemia, bloodstream infection. And we know about half the time from old autopsy data, candidemia is complicated by end organ infection as a result of hematogenic seeding. But there is this third entity of deep-seated candidiasis, DSC, from direct introduction of Candida into a normal sterile site. The most common form of deep-seated candidiasis is, in fact, intra-abdominal candidiasis. So, Candida colonize the gut, and at sites of disruption of the gastrointestinal tract or the hepatobiliary tree, you can get leakage into the abdominal cavity. And at the University of Pittsburgh, in our intra-abdominal candidiasis, about 60% of cases are walled-off abscesses, as in the patient I presented. About 40% of abdominal candidiasis is more generalized peritonitis. In the literature, that percentage is generally flipped. So most places will report more peritonitis rather than abscesses, but these account for the preponderance of disease, and then a smaller percentage of things like infected pancreatic necrosis, cholangitis, cholecystitis will be encountered. And the way we teach it is that if you consider candidemia in your hospital or in your critical care units, the risk factors are relatively non-specific and they're broadly common, particularly within the ICU, right? So almost everyone is on broad spectrum antibiotics. They have IV access devices. Many are mechanically ventilated, have renal insufficiency. They receive steroids or otherwise have immunosuppression, and many are candida colonized. In contrast, abdominal candidiasis should be thought of as a high prevalence disease among more narrowly defined patient populations. So your patients are going to have the typical candidemia type of risk factors oftentimes. However, this disease is largely concentrated in people who've had disruptions or problems with their gastrointestinal tract, right? So liver transplant and hepatobiliary surgery, severe pancreatitis, or other disruptions of GI tract or peritoneal cavity integrity, including peritoneal dialysis. So we've published our experience at the University of Pittsburgh on abdominal candidiasis a couple of years ago, and it's interesting to contrast it with where we are right now with candidemia, right? So on the left here, we show our UPMC, University of Pittsburgh Medical Center candidemia data, where in any given year, albicans and glabrata, or glabrata and albicans are going to be 1-2 in terms of causes of bloodstream infection. And then you're going to have a sizable chunk of peropsilosis at our place, usually about 20%. On the other hand, intra-abdominal candidiasis microbiology resembles that of candidemia really from probably 20, 30 years ago, early in the Azole era, where Candida albicans still accounts for the bulk of the disease. About a quarter of cases are glabrata, and then smaller numbers of peropsilosis or other species. So still an albicans predominance at most places for abdominal candidiasis. In candidemia, about a third of cases are going to be complicated by bacterial co-infection. By definition, at least using culture diagnostics, blood cultures are going to be positive. And nowadays, if patients survive long enough, they generally will receive antifungal treatment. The mortality rate at our place is at 100 days about 50%, and in the literature, typically 20 to 40% for candidemia. So bacterial co-infection is more common during abdominal candidiasis. 2/3 or more cases, as in our patient, will also have bacteria present. Blood cultures, as a rule, are negative, less than 20%. At our center, less than 10%. And a notable difference is that where almost all patients undergo drainage or some sort of source control intervention, in fact, about a quarter of patients will not be treated with an antifungal. So treatment is kind of where we were with candidemia in the pre-Azole era, where oftentimes clinicians will come by, they'll see a culture, they'll start treating the bacteria, and then they'll make an ad hoc decision about whether they're going to use an antifungal. The mortality rate is a bit lower at 100 days, more on the order of about 30% as opposed to 50% with candidemia. And if we look at the outcomes are significantly better for patients with abscesses, shown up here in the top two lines, green and blue, than they are with the various forms of peritonitis. So that makes sense in that you've got a more localized infection that, at least in theory, should be more amenable to a surgical or other corrective intervention. So if we look, again, from our data at independent predictors of outcome, in addition to prompt source control, younger age, the presence of an abscess specifically, and then the institution of antifungal treatment within 5 days are all independent predictors of survival with intra-abdominal candidiasis. So we say for abdominal candidiasis, if you're getting a culture, it's a sterile site, freshly collected culture, go ahead and treat all patients just as you would do with candidemia. So in order to treat, you have to make the diagnosis. Blood culture sensitivity, as I said, is less than 20%. But even if you do a biopsy, if you look at the literature, the sensitivity overall for abdominal candidiasis is only on the order of about 40 to 50%, and it's lower with prior antifungal exposure. And the reason for that, as we show here in a mouse model that we've developed of abdominal abscesses, is that the candida are relatively scant and dispersed within abscesses. So depending on where you sample, you may or may not happen to capture the candida that are there. So given the challenges with diagnosing all forms of invasive candidiasis with cultures, there's been interest in non-culture diagnostics. And I'll leave this up for your consideration, and I won't walk through it, simply to point out that the bulk of the literature for any of these tests has been in candidemia, and you cannot necessarily extrapolate test performance from candidemia into deep-seated or intra-abdominal forms of disease. To point out, however, that for the literature that is there for all of these tests, the sensitivity and specificity are reported as slightly lower for abdominal candidiasis in general than they are for candidemia. For beta-glucan, sensitivity, specificity for abdominal candidiasis on the order of about 60, 65% and 65 to 75% respectively across studies. And then for T2 candida, sensitivity probably more on the order for abdominal candidiasis of about 40%, but maintaining the excellent specificity that you generally see with candidemia. So the key is you got to know, if you're using non-culture tests, what's used at your center, and then what's the performance in the relevant clinical setting at your center. And if you know these things, then you can make rational use of non-culture diagnostics. And the reason you can is that we know for both candidemia and invasive abdominal infection populations that the prevalence in particular settings of candidiasis is actually fairly well defined in the literature. So I'll walk through abdominal candidiasis. We've got papers that have taken this exercise also with candidemia that you can look at. But the prevalence of abdominal candidiasis in various risk groups ranges from low, which are, say, your low to moderate risk peritoneal dialysis patients with peritonitis, about 5% of whom are going to have candida, through other populations to your highest risk group, which is the high risk gastrointestinal hepatobiliary surgery patient, like I presented, patients with biliary leaks, or upper GI tract, gastric or duodenal perforations. And there the prevalence is about 30%. And then intermediate populations with other gastrointestinal disturbances. So if you know the relative prevalence in your particular patient population, and you know sensitivity, specificity of different tests from the literature or from your own experience at your center, then you can estimate what you're really after, which are positive and negative predictive values. So for any test, as the pre-test likelihood or prevalence increases, the positive predictive value is shown in the red boxes here is going to increase. And conversely, your negative predictive values are going to decrease as your pretest likelihood increases. So how do we actually use these, or how can we use these in clinical practice? And this is where it gets tricky, right? Because we don't really know what the threshold of disease likelihood that justifies antifungal treatment is. So if you look at the antifungal prophylaxis literature in critical care settings, in hematopoietic stem cell transplant recipients back in the day, antifungal prophylaxis may be beneficial in preventing invasive fungal infections if rates of disease are somewhere greater than 15 to 30%. If you ask clinicians, 30% is often a figure that gets bandied about for thresholds to treat these type of things. Kind of empirically, that seems right to a lot of people. So your target positive predictive value for a test is going to be on the order of 15 to 30%, and a negative predictive value would ideally be 85% or above. So if we construct then a figure of pre-test probabilities shown here on the x-axis, and then the y-axis post-test probabilities for various patient populations at risk for candidiasis, in the absence of testing, the black line here, this straight line, your pre and post-test probabilities are the same since you're not doing a test. But if you do a test, you get a positive result, then you can shift this post-test probability up to the blue line here. So let's just say I'm going to have a 30% threshold to treat someone. We draw the red line at 30%. And what you're after then is the population where you go from below the red line at 30% likelihood to above the red line with a positive test result, while maintaining a satisfactory negative predictive value. So you're confident that you're not going to be missing significant number of patients who do have the disease. So with that, what you see is these non-culture tests really work within a window of utility. At very low pretest likelihoods, your positive predictive value still stays low. And although your negative predictive value is very, very good, in effect, you're starting with an excellent negative predictive value. So the test really adds nothing. Conversely, at some high risk of disease, you may have a situation where a positive test brings you high, but you're already pretty high, and you may want to just treat even without the test. And moreover, your negative predictive value begins to decrease, and now you have to accept an increasing number of patients who may have disease who you wouldn't recognize and wouldn't treat. So on a high end, the test may not have value for you either. So if we go to try to find these windows for abdominal candidiasis with different tests where we go below a threshold to treat to above, you can see for various tests where you might anticipate you derive value from using the test. Now for T2 Candida, with the published sensitivity and specificity for abdominal candidiasis, it's somewhere in this 15 to 20% emergent intra-abdominal infection, colonic perforation, acute pancreatitis type populations. But you're probably not going to get value in patients with peritoneal dialysis who are low risk. And your high risk patients, your negative predictive value now drops to about 80%. So you've got to accept the significant risk that these patients are going to have disease even with a negative test. So does this really work? These are theoretical considerations. So if you had a hypothetical population with a 20% prevalence, based on beta-glucan data, you'd anticipate positive and negative predictive values of 24 and 90% respectively. And in fact, if you look at the literature, this is a recent study out of the Swiss group showing that in that very population, using beta-glucan, they had 30 to 35% positive predictive value and about 90% negative predictive value. So these tests can work if used rationally and judiciously. So let's return to our case. The likelihood of invasive candidiasis before you get the data back, as most of you guessed, probably was about 30%. So bravo. Of course, our patient was treated, and then we got this data back where the T2 was positive, but the culture results are negative. So if we walk through that, we're starting at about 30% before we get the tests. Intra-abdominal cultures, blood cultures, despite their limitations, they have some degree of sensitivity. So, intra-abdominal culture negativity, blood culture negativity are going to reduce the likelihood probably to about 15%. And based on that and T2 performance, we'd expect a positive predictive value of about 50%. So 50-50. The negative predictive value would expect it to be about 90%. So the question then is, this is probably high enough to treat as a positive result, or are you willing to accept the 10% chance with negative results being a false negative to withdraw treatment? So the summary is that you can get strong positive predictive values, but you're going to miss some cases, and then it's a matter of what your threshold for pain for potentially not treating people who have disease is. So let's return to our other question. Would antifungal treatment be justified? Nowadays, we're treating everyone who we get a positive culture on. I think the pretest likelihood was sufficient to justify treatment without waiting for your data to come back. So I would have said yes. And then the question is, what's the best treatment option among the choices there? And it comes down for most people a choice between fluconazole and echinocandins. If you look at the IDSA guidelines, they address intra-abdominal infections. And what they say is they would empirically treat people if they have clinical evidence of an intra-abdominal infection and significant candidiasis risk factors, such as anastomotic leaks, necrotizing pancreatitis, recent abdominal surgery, as in our patient. So IDSA would have recommended treating this patient empirically. And they say the choice of agent is the same as for candidemia. So first choice for them would be echinocandin. And then you treat based on, for duration, based on your ability to obtain social control and clinical response. So, is an echinocandin the right choice? And what do we know about echinocandin pharmacokinetics within the abdominal cavity? There isn't a ton of literature, but the human studies that have been done suggest median ascites concentrations of caspofungin from about 0.2 to 0.5 micrograms per ml, and a little bit higher for mycofungin and for inidulafungin. So these are significantly lower than plasma. The data suggests that they're sufficient to prevent candida proliferation in many cases, but may not consistently achieve eradication. The clinical trial data suggests clinical response rates about 60 to 80% in cases of peritonitis. Fluconazole, on the other hand, ascites and plasma concentrations are comparable. So we tend to use fluconazole, but there's really no correct answer, I think, for that, and probably comes down to experience at your center. There's almost no data on abscesses. We have done some animal model experiments with David Perlin, looking at intra-abdominal candida abscesses and measuring levels with mass spec. And what you see is that within abscesses, after 2 doses of mycofungin and 3 doses of mycofungin, you can achieve concentrations of 3.5 and 5 micrograms per ml, respectively. So much better than you seem to do within ascites generally. And just to show here, the new agent resifungin achieves very, very high intra-abdominal abscess concentrations after a single dose. So whether this will end up meaning anything or clinically, we'll have to see as that drug enters the clinic. So just to wrap our case up, patient had recurrent anastomotic leaks. Intra-abdominal cultures 2 and 6 weeks after the original cultures are now positive for glabrata, which is initially susceptible. There's multiple negative blood cultures still. He received multiple courses of mycofungin, lipid formulation amphotericin B, but source control was never attained, and he died of septic shock 6 weeks later. And his terminal blood cultures now, for the first time, are positive for Candida glabrata. Now he's carrying an FKS2 mutation that conferred echinocandin resistance. So obviously, multi-drug resistance has been on the rise, originally with fluconazole, but now increasingly with the echinocandins. These were data published by Barbara Alexander out of Duke. University of Pittsburgh data, though, closely track with these. We see about 10 to 15% echinocandin resistance among glabratas. You know that most resistance is conferred by mutations in the FKS genes that encode the echinocandin target, beta-glucan synthase. And within hotspots of this gene, mutations confer both inhibition of glucan synthase and corresponding increases in echinocandin MICs. So what's our actual clinical experience? If we look for albicans and glabrata, where this has been most relevant at our center, our overall glabrata echinocandin resistance rate had gotten as high as about 18%. With stewardship now, we're at about an 8% rate among all glabrata. But the important point here is we almost never see resistance or mutations in the absence of prior echinocandin exposure, and most particularly as part of breakthrough infections. And the numbers are low with albicans, but it's the same trend where the overall resistance is only about 3%, but with breakthrough infections, about half are going to be resistant and carry these FKS mutations. So with that, our treatment algorithm is that if we have prior echinocandin exposure and or an elevated echinocandin MIC, we're going to avoid use of these agents. And with that, you can stratify responses and predict your likelihood of response. But if we don't see resistance and we've not had prior exposure, intra-abdominal candidiasis responses at our center with the echinocandin remain excellent. So just to summarize echinocandin resistance, it's usually, but not always, seen with FKS mutations. You will have some isolates that have discordant resistance patterns, typically resistant to caspofungin, but susceptible to the other echinocandins. The significance of this is not altogether clear. Is it a breakpoint artifact? There's some data out of the Perlin lab that this is associated with specific sphingolipid mutations. But I think the important point to take home is that FKS mutations are pretty hard to induce during treatment of invasive candidiasis. You rarely see them without prior echinocandin exposure. And even in our patients with prolonged exposure, invariably we'll still detect wild-type echinocandin susceptible FKS mutation, non-FKS, wild-type FKS strains. And resistance rates in the literature, and including in our place with echinocandins, may be overstated due to a decline in the overall diagnosis by culture of candidemia in recent years, and by the reporting of breakthrough cases, which is disproportionately where your resistance is encountered. So I think for antifungal resistance among Candida in general, the species that are your frontline concerns are Krusei, which is intrinsically fluconazole resistant and has been recognized really since the introduction of fluconazole to the clinic, particularly in hematopoietic stem cell transplant recipients. More recently, obviously, Candida auris, although there is phylogenetic and geographic clade differences in susceptibility patterns, in general, almost all are going to be fluconazole resistant. About a third are going to be amphotericin B resistant. Echinocandin resistance remains quite low overall, and they're your drugs of choice against auris. Glabrata, emergent resistant to just about any antifungal with prior exposure, particularly with breakthrough infections. And Propsilosis has been recognized for having diminished echinocandin susceptibility intrinsically. It's an important cause of echinocandin breakthrough infections. In directed treatment, the significance is unclear of this diminished susceptibility. IDSA guidelines are, if you've started a patient and then you discover it's a Propsilosis, but he's had a clinical response to the echinocandin, it's okay to continue it. And increasingly now, Propsilosis has been linked to fluconazole resistance. Studies out of Spain and elsewhere describing this phenomenon in particular. So overall, in conclusion, remember that invasive candidiasis is more than just candidemia, that at some centers like the University of Pittsburgh, we actually encounter more intra-abdominal infections than we do bloodstream infections, reflecting our patient population mix. So you got to know what you have going on in your own shop. In many ways, the current management of abdominal candidiasis resembles that of candidemia 25 years ago, where patients, a significant minority, will not receive antifungals, but should probably just go ahead and treat anyone you're getting a sterile site culture positive from. Albicans still predominates in abdominal candidiasis at most centers, and the key to management is really source control with parental antifungals as an important adjuvant. Non-culture diagnostics for abdominal and bloodstream candidiasis can be useful if used rationally. I talked about T2 Candida here. You can apply the same thing as an approach to beta-glucan or tests that might come down the road in the future. But these only work, I think, really if they're folded into diagnostic stewardship approach. So you just can't let clinicians order and try to interpret them willy-nilly. They really won't be able to make systematic good use of the testing. Antifungal resistance is increasing among Candida, but keep it in perspective. Outside of intrinsically resistant species such as auris, really it's seen among people who've received prior antifungals and extensive exposures in often cases. And I think important questions are, where are the new agents, resifungin and brexafungin, going to fit into practice? Will they have utility either because of their pharmacokinetics in the case of resifungin or their unique target in the case of a brexafungin against some echinocandin resistant infections? We'll have to see. It's inevitable. We're going to see the emerge of less susceptible species in the future as well. What will they be? Where will they be from? What's going to happen with auris and Propsilosis? And are there any future prospects that we might personalize dosing based on individual patient pharmacogenomics and pharmacodynamic considerations as we're moving to some extent in the bacterial field? So I'll close there. We can open it up for the questions. But if we don't get to anything, or if you have questions down the road about cases or things you run into, please feel free to get a hold of me. I'm still on Twitter, which, could be very different next week, but, DM me or drop me an email or what have you. I'd be happy to answer. So thank you, and we'll open it up.
Thank you so much, Neil. Again, another really excellent case illustrating. I absolutely loved those tables. In fact, I took photos of them because they're so useful when you're trying to write algorithms, and we all know that there's having BDG available, but then it's how you actually use it in this patient population. So we need to get that information.
Yeah, let me just say, because when I show this to our group and what have you, I think it intimidates a lot of people. The point isn't memorizing the numbers. The point is there are patient populations you can use these tests the way you use a galactomannan, and you don't even need to do, as we'd say, the math, or you'd say the maths. You know, you can have confidence the test will work a certain way, and then you decide, you know, are those likelihoods enough to drive your treatment? But we've shown that you can shorten time to treatment and you can reduce antifungal use in intensive care units with, for example, T2 testing if it's part of diagnostic stewardship. So, you know, that's what you have to decide. Is it worth the effort to put that together? But if you do, you can make it work. And you can go, we've written a couple review papers on this. The tables are written there, so you can just sort of reproduce them out of the tables as well. I'm happy to share the slides if anyone wants the slides.
Thank you. Now, just to give Neil a bit of a breather, if I can start off maybe with a question for Paul in the chat. So we have a question from Liz Johnson from Bristol. I'm sure you can see it, Paul, or maybe you can't, but she says, great talk. Do we know anything about the bone penetration of olorofim?
Yeah, so you thought I'll start with an easy question. Yeah, I think there's not much yet in the public domain on the tissue penetration of olorofim, but I know that there are some cases where secondary site infections were successfully treated with olorofim. So I know one patient who had azole-resistant cerebral aspergillosis who had a very good response to olorofim therapy, and we also had a patient with chest wall invasion, including ribs, who also had a very good response to olorofim. So I think in general, it probably has a good penetration into these difficult tissues.
Okay, one more question for you. Really easy, Paul. There was one actually that I was curious about as well. Somebody asks, can you tell us a bit about use of anakinra in patients with pulmonary aspergillosis? Which patients are good candidates for this? When would you use it? One-off dose or repeat dose?
Yeah, so that's also a very difficult question because we have a highly experienced infectious disease professor here, Frank van der Veerdonk, who is really keen on using this receptor inhibitor, IL-1 receptor inhibition. So the background idea is that in certain patient groups, and especially in patients who have viral-associated pulmonary aspergillosis, so influenza or COVID, you get dysregulation of the cytokine response. And if you have a reactive response, then anakinra could help to reduce that. And the idea is that that would be beneficial for the infection. So this is in no way a recognized treatment. It's more like a conceptual treatment of these patients. And we've used it a few times in patients with very severe aspergillosis in influenza and COVID. In this patient, it was given once. And later on, interferon gamma was administered, which actually has like the reverse idea behind it, because the idea is that you then develop immunoparalysis, and that interferon gamma might help to clear the fungal infection. So also for this treatment, there's, I think, very limited evidence yet that this would be helpful in these patients, but it's very much a conceptual approach, which we do in patients who respond very poorly to our treatment.
Thank you.
Some questions for you, Neil. When to treat candidiaria?
When to treat candidiaria? Yeah, almost negative. Almost never.
But how do you manage if you have a patient on the ICU with candidiaria? What is the plan?
So generally speaking, you don't treat it. I think in most ICU patients in whom you're culturing candida out of the urine, oftentimes it's out of an existing catheter. I think it is important, though, as a marker of candida colonization. And from that point of view, it's a risk factor for the development of invasive disease. So if I knew a patient had candidiaria or candida cultures elsewhere, and they had other signs that pointed to invasive candidiasis, I would factor that into my risk stratification for the likelihood of candidiasis. I mean, we will see it in transplant recipients, and you can see it as part of disseminated infection, but sort of an isolated candidiaria off a culture that's sent, we almost never end up having to treat that. The other thing to realize is that a teaching point is that the UA in no way correlates with significant candida in the urine. So you can't use the parameters you're taught to use for bacterial interpretation of a UA. The white cells, the other parameters don't help you at all.
Okay, and you mentioned the kind of using it as a colonization measure. Do you use any kind of risk-based profiles to kind of, because you showed all those numbers, would that increase the likelihood of somebody having candidemia or invasive abdominal candidiasis?
Yeah, we don't systematically screen people for colonization just because of the burden of work that it presents. But clearly, colonization and more sites of colonization is a risk factor for subsequent disease. So if you had that data and you had someone who had other risk factors for candidiasis and they have a clinical syndrome for which you have no explanation, then it all goes into sort of a stew. But we don't systematically use the prediction scores, say, for example, the MSG score or the Candida Colonization Index. In our medical intensive care unit, we know after 3 days, if you're in sepsis and there's no cause of the sepsis, that 3 to 5% of our patients will have positive Candida blood cultures. If you use T2 Candida or beta glucan in that population, you can get positive predictive values on the order of about 30 to 35% with excellent negative predictive values. So we use these risk factors to identify who we're going to do the non-culture diagnostics in medical intensive care units for candidemia and in surgical intensive care units like the case I presented.
Okay, thanks. And then a last question, Tiana, before going back to you. There's a question from Arnaldo Colombo, also for you, Neil. Congrats to both speakers, he starts off with, but considering the low penetration of candins in intra-abdominal cavity, plus the low plasmatic exposition of candins in critically ill patients, don't you think we should revisit the dose of candins to be used to treat intra-abdominal candidiasis?
Well, personally, yes. We tend to use fluconazole in those patients, like in the case I presented, for the reasons that Arnaldo lays out. If you look at the literature, there's no obviously randomized controlled data, but the literature out there suggests the response rates with echinocandidates for abdominal candidiasis are on the order of 60 to 80%, and there's no evidence that they're inferior to fluconazole or other choices. So the data really aren't there. It comes down to what you're comfortable with. But we do know fluconazole gets excellent abdominal penetration. At the end of the day, in the abdominal cavity, the source control and site of infection remediation is what's most important. So we're perfectly comfortable using fluconazole. And personally, I think the IDSA recommendations are a bit strong for an echinocandin given the lack of conclusive data.
Okay, thanks.
Thanks. Just before I launch off into the next question for Paul, Neil, just following on from that, you mentioned that in your institution you have an algorithm for what happens if you've got echinocandin significant pre-exposure. So what do you use in that situation? And do you think we should be changing, given, you know, there is emergent resistance to especially echinocandins at that site? What do you do? Do you use different drugs? Do you use combinations?
Yeah, if we have breakthrough infection, we use a different drug. That'll generally be fluconazole. However, there may be cases where they've also had fluconazole exposure or fluconazole resistance, in which case, you know, you're left with lipid formulation amphotericin B. This is largely where we see our real antifungal exposure is in our surgical intensive care unit with our liver transplants and complicated GI surgery patients. So that's really what we're talking about. And then the question there is going to be, yeah, could these newer agents that are going to be a bit easier to tolerate than lipid formulation amphotericin B, could they potentially offer something either based on pharmacokinetics or in the case of Abrexa, you know, the different target? But that's, you know, that's not clear right now. The issue of prior exposure in our medical intensive care unit with candidemia at our place is a lot less relevant than the abdominal population.
Wonderful, thank you. Now, on the topic of resistance, Paul, Martin Weihert has a question for you regarding you mentioning the possibility of mixed infections with different Aspergillus fumigatus isolates. Do you mean a mix of azole-resistant and azole-sensitive isolates? If so, would the early combination of an azole plus amphotericin B help to prevent the expansion of the azole-resistant isolate, which otherwise gets selected for with azole monotherapy?
Yes, thank you, Martin. This is, I think, a very interesting question. And it is indeed the case that if you have a positive culture and you have multiple colonies and you would analyze all these colonies individually, that you might find that maybe the majority is azole sensitive and maybe a few are azole resistant. So that I think if you think about it, it kind of makes sense because we inhale these spores and that also would be a mixture. And we actually, in patients who died of invasive aspergillosis and who underwent autopsy, we try to look in individual nodules in the lung to see what kind of genotypes were present there. And we indeed found that some of the nodules are azole susceptible and others might be azole resistant. So my idea is that actually each of these nodules in the lung originate from a single spore, and these may be genetically different. So if they're all azole susceptible, it doesn't matter. But if some of them are azole resistant, it does matter. And we've had patients actually who were treated with voriconazole and then they disseminated to the brain, and in the brain we found an azole-resistant isolate. So this makes the management very difficult because usually you don't have a lot of colonies. So if you find a susceptible colony, if you only have one colony and it's susceptible, then you can't actually rule out that there's resistance. And also our experience is if you start treatment with VORI in these patients, actually they improve clinically, because you are treating these susceptible lesions, but the resistant ones you're not treating and they then disseminate. So your question, I think, you know, should you start then with a combination is very relevant, but I think it very much depends on the frequency of resistance. So in the Netherlands, we have quite a high frequency, above 10%, and we decided in 2017 actually to start combination therapy in all patients, unless we could rule out resistance really early. and then de-escalate when the patient is improving or we are convinced that they have an azole susceptible isolate. So we are considering this strategy and evaluating that. But if you have a low prevalence, I don't think this would be a good strategy because you overtreat a lot of patients. So actually it remains, I think, a dilemma, and maybe with PCR testing, you could pick up the mixed infections even in patients where you maybe only have one colony or where you have a negative culture.
Yeah, I think that's really interesting, because this whole issue of heteroresistance in the resistance field, particularly with azoles in Candida, and also, as you know, we described it in Cryptococcus, and we showed that it was selected for by fluconazole in patients on therapy, whereas if they were on combination therapy, that heteroresistance was actually suppressed and not selected for. So I do also wonder whether, you know, combination therapy may be a strategy, and we're missing these tiny heteroresistant subpopulations, even if we do MIC testing, and your audience showed, and it's the same for us here in London, that very often we don't know what our prevalence of azole resistance is because we don't send it off. We just treat it, and then only if they're failing, we might do an MIC. So maybe in Holland, you're just more aware, and actually there's a lot more resistant subpopulations out there than we realize. So I think I think your strategy is quite forward thinking, especially as we know that the TDM, you know, that the VORI may be underdosing. Now let me just see if we have any more questions. I don't know, Adelia, would you like to do any more for Neil?
Yeah, maybe we can pick one. We have only 2-3 minutes. No, I think the questions which are there are for.
There was
one question I typed an answer to, Adelia, about combination testing, and I get asked this a lot. So it's potentially incredibly powerful if it's used carefully. So the likelihood ratio with combination testing is the product of the likelihood ratio of the individual tests. So what that means, if the results agree, it explodes your positive and negative predictive values. However, if the results don't agree, depending on the performance of the individual tests, you may be right back where you started, or you may be worse off than where you started. So if you think about it carefully and you know what you're going to do with the results, then it's potentially very powerful. But used indiscriminately and without thought to whom you're testing, it could actually be potentially confounding. So be careful with combination testing, but in some patients, it does add real value.
Yeah. Okay, thanks. I think we need to draw to a close. Diana, are you happy to?
Yes, absolutely. So I think we've had an excellent, two really excellent and illustrative clinical cases that have really addressed some of the issues we face day to day in these patients that don't necessarily conform to anything that's written in a guideline, from two renowned experts in these fields. And I've certainly learned a lot. I hope you have. Thank you very much to the audience. We had I think we had over 100 participants at one stage. This is being recorded, so tell your friends and colleagues they can watch it on the MRC CMM YouTube channel. So it's an excellent reference, and thank you very much to both the speakers and my co-chair and all the audience for their questions and participation.